Smokey out in the Center Performance and Quality Committee order. And appreciate Mike, thank you for being here, also for chairing it last month when I couldn't be here. Jeff, good to have you here. Probably last one. Can we go around the table and introduce ourselves? I don't know how you want to do it. Obviously,
However you want.
go ahead. Why don't you start? Make sure everybody knows.
Julie Sinclair, Senior Director of Quality and Integrity Operations. And I brought some of the staff that actually work on the reports so that you might get just a little picture of what goes on behind the scenes. So.
I'm Steve Leger. I'm the business specialist for QIL.
Why don't you tell them which reports you work on?
I work on the monthly MCO report that goes in every month on the 20th. I do the comparison report, which is an extensive series of graphs which is drawn from the state's comparison of all the MCOs on using the monthly report. I do the board trending slides, the PowerPoint presentation which shows Smoky Mountain's graphs for the past 12 months, and the provider satisfaction survey. That's mine too. And the access to care report. Thank you.
My name is Stephen Kazicki. I'm the QM director. Functions that I kind of touch all of them, but then mostly I work with the grievance team and the grievance and complaints. I do the performance improvement grid, all the DMA, DMH measures. Those are in my shop as well.
And I'm Yvonne French. I am actually with the Division of Mental Health, and we've gone through a recent little bit of reorg, and so I was previously assigned as liaison to Centerpoint and Partners, and to kind of round out the Western region, they've assigned me to Smoky as well.
So basically, you get to I-77 and start working.
Exactly.
Good to have you with us. Thanks for coming.
My name is David Boki. I'm the Director of Risk Management, and the reports that I work on are the incident report summary, which we're going to look at today, and then the backup staffing report summary.
Now, you listen to a trial class, I serve as a county manager for Rutherford County and the chair of this committee when I'm able. No, I do appreciate it. And can we get a motion to approve the agenda?
I just have a question
Yes.
for you. Are you remaining on the board?
For a little bit longer.
Okay, so we don't need to discuss a new committee member or anything until you'll let us know.
Y'all are welcome to anytime you like.
No, we like you.
You're welcome.
Sorry, not that easy, but just trying to plan ahead.
My contract runs through February 20th. I'll go part-time after that until they find a new candidate.
Oh, okay, good, so you'll stay.
I'll stay for a little while
Good,
longer.
good,
So.
okay. Then,
I'd just like to say to you all who do these reports, these are terrific.
Yeah, these
You
are
do
amazing.
a really great job, and in fact, it was just yesterday at the Western North Carolina network of CEOs of hospitals. I made reference to the high quality of work that comes out of this department in terms of really excellent reporting, and many of us could use this data for planning and especially as we're trying to plan more integrated health, and you all do a really terrific job. I don't know if you get pat on the back enough, but I'm doing that right now.
Thank you.
And that's work, really nice work.
Motion on to approve the agenda. So moved. For a second? All those in favor say aye. Aye. Opposed, nay. We have copies of the minutes that were handed out. Again, do appreciate Mike, you chairing last month, of course, when I couldn't make it. You have a chance to look at the minutes, or if you'd like to take a moment and look at them. Anyone have any questions? Just change? A motion to approve the minutes, please. So moved. A second. All those in favor say aye. Aye. Opposed, nay. Those minutes are approved. Julie, I'm turning over to you for this point forward, the monthly reports, if I may. Thank you.
thank you. I will let Stephen Kazicki give you the highlights of the performance improvement grid, and then you can ask him any questions that you have about that. Again, this is the legal-size paper that has, again, I'll just remind you that this is the summary of all corrective actions that we are working on from external reports at SMC.
So I'm happy to report that over the last month, we had our monthly reports, and a lot of those, I'm looking at that first section, we have accomplished our goal and met our standard. We're getting close to being able to take a couple of these off the list, so that's really exciting. The complaints and grievances, as well as the call center, answered within 30 seconds. The call center being at 97%, and the complaints being at 93%. Access to care, we did have some things drop.
On the call center, and you may not be able to answer this, and maybe somebody can look into it. On the calls, how many calls does the call center receive on a, I missed that, I'm sorry.
Yeah.
And the question I have is, how many of them are from different people versus how many are from the same people? Do we break that out? Okay, so the same person, if they call 6 times, it shows up as 6 calls. Okay, that's what I was really doing. Okay, thank you very much, excuse me.
Now, the uniqueness on that is the call.
Not the
Not
caller.
the individual.
Okay,
Correct.
thank you.
So the access to care report, the first one being that emergent calls determined within 2, and getting started within 2 hours, 15 minutes, sorry. And you can see that we were below standard in the first quarter of the fiscal year 14-15.
Now, is this compared to the metropolitan areas also?
Yes, this is all of it combined.
So our 23 county area is compared to like Mecklenburg or Wake or something. I mean, I know there are other areas. Okay,
Same
thank you.
standard, same everything.
And how is the, I mean, I think we discussed this before, but I don't remember. What are the standards based on? Is this an arbitrary set point, or is this national standards of some sort? So it's just a contract, so somebody just brings up that 93.5% or whatever the number is the standard.
Well, the state standard is the average from the previous 12 months.
Okay,
And that's put into the contract.
okay, all right, okay, so it's state standards for the previous,
State average.
state average for the previous 12 months.
So it doesn't differentiate. This is where I get that. If you're ECBH or Smoky, part of the state average includes Wake and Mecklenburg. That's, take it back to you, we're harder to hit some of these in rural areas anyway.
Well, that's some of we're just now getting to a point where we're measuring the same way,
Right.
using the same method.
Yeah.
So
And I understand, all this is, we're all working, it's just pet peeve of mine.
So we moved.
Exactly.
So we moved to the urgent determined calls. Those have to be responded to and provided service within 48 hours. And you see those scores that we've consistently been below that average.
That's the thing that concerns me there is that we seem to be going.
It's worse.
Downhill. We went from 75.7 down to 66.6. So we're 3 quarters, and that bothers me.
We're working on that. We've got several different things we're looking into. One of the topics that kind of sticks out a lot, especially with the call center, is anybody that calls in that has a substance use diagnosis, regardless if it happened 20 years ago or not, they're still considered urgent. So if they're calling in and they've had a diagnosis before, they're still considered urgent, but it could be that they need a med check in the next 2 weeks. So they're still considering house county against this. There is discussions and there is talks about figuring that out and make it more true, make these numbers more true, so that is in the works, and that's across the entire state.
But that's a state standard, right? And the standard that they set.
Technically, if they're calling for a substance abuse issue, they should be seen as urgent because the window of opportunity for substance abuse treatment is so short that that's. But I
because I agree with like Mike says, the problem is for some reason, we're going the wrong direction.
This plan of correction that's put here is a new plan of correction.
Oh,
So
it is?
they-
Okay.
So, yes, we are going in the wrong
Right.
direction, and this plan of correction was, became a lot more detailed in the past month.
All right.
Right.
So let me make sure I understand you, Ms. Claire. When you say that they should be considered urgent, when you say consumers,
Yes,
right?
if they're seeking SA treatment, yes, the state access to care directive is that they are to be considered urgent.
But now what you seem to be saying is that you don't think
If
they
it's-
should be.
If they're seeking SA treatment, then they should be considered urgent. But if they have a diagnosis in the past, they're automatically labeled, even if they're seeking mental health services.
Gotcha, okay. Now I'm seeing the differentiation.
Interesting note in here now, read this more closely, you explain it. The national average for intake is 50 to 56%, yet the state of North Carolina sets a much higher threshold. Why is that? Is there a reason for that?
Not that I'm aware of, except for they use the metrics from the previous year to get
Yeah.
the state average and the state targets.
I mean, I think it's got to be the methodology by which state standards are determined. Because if you're constantly rolling in the new average, the bar keeps getting higher and higher, which is exactly, there's a good, that
Right.
there's some method to that.
Yeah, it's not a problem, it's interesting.
Yeah.
I guess I don't see a problem with having higher and higher standards.
Exactly, it's not a problem, it's not, that's what I'm saying, it's not a problem with it rolling up higher rather than rolling down lower, and we're going the wrong direction right now, is what I'm hearing you
Yeah,
say.
right.
I think, I guess the good news is that we achieved the national average, if you look at our numbers. Bad news is we don't achieve the state average.
But of greater concern that I have is that we're moving away from it.
Yes.
And that's the part that's got me, in that area. But I also understand there's classification issues and a number of other issues. In order for a hospital, the consumers discharged from ED after being detoxed in ED often do not stay sober to follow up with an outpatient appointment. That's a problem we probably face in our county, the high level of use.
So what percentage of the folks who are being categorized in this measure are SA clients?
I don't have that.
We'll have to dig
I'll have to
deeper
get
for that.
into that.
I mean, just what would your guess be?
That could be the best.
I mean, because of the.
My guess would be that it's at least 80%.
Okay.
We can dig into that.
It sounds like from what you're saying that the couple of bigger issues are that hospitals are not knowing peer support folks in there, and that in addition, the consumers aren't happy with that group model. So does that mean we need to provide more, a different type of care to get them more engaged in that 48 hours?
We just need, these are things that we need to explore, yes.
We need to belabor that.
That's
Thank you,
okay,
Mike.
just move through and highlight the new items.
Okay, so, I do want to say that CDW issues that came up, we are working diligently on those. We've got a team in to help us correct that. So I just want to make that note. The new added measures is number 4, the IMT corrective action items. These came from our IMT visit. Stuff on the bottom page 4. So here, these are brand new to us, and I don't want to take a lot of time, because I know we got some big things coming up in the future, or later in this meeting. But we started our corrective action plan. Part of my team is the system performance team, which works with the individual departments that focus on these type of things, to where we need to correct these options, correct these items on a global scale. So my team is working with the departments individually to get into these precise measures. What you have on the corrective action plan is kind of our first step at these, first crack at these. So is there anything that kind of sticks out that we want to discuss in those?
Letter E, I just can't stress it enough. It just says the provider, the availability of providers issue. So those of us in smaller counties, it has been, continues to be, and will be. The comprehensive provider approach has really resolved a lot of issues, but it's still a problem.
All right, next we have who's looking us that is the provider satisfaction survey. This survey just came out, and I think we're going to talk about this a little bit more. We're going to have a whole different, more in detail description of all these measures. So instead of stealing his thunder out and talk about that one a little later. But I do want to say that my team is also working on these with the different departments as well.
Thank you. If we don't have any more questions about that, we'll go to the DHHS MCO monthly report, which is October data. Although it's December, the data is due internally on the 10th and then externally to the state on the 20th, so we don't have a November report. So we are going to review the October report, the October trending slides, and then have an executive summary as usual. So I will let Steve do that, and then we will move into the LME MCO comparison, which is September data, but it includes data points that are provided to us by the state that are all the LME MCOs, and you can see how our performance compares to other MCOs across the state. So, Steve Leger, I didn't bring the other Steve, we have Steve. No, Steve, and who's the other?
There's a lot of us.
Yes.
Speaking of a lot, there's a lot of data. The MCO monthly report has a large number of measures. I'm going to try to hit the high points. If you have questions, please stop me. The monthly MCO report gets a little bit complicated because there's a DMA side and a DMH side. We measure both Medicaid consumers and state-funded consumers. The other issue that complicates it just a little bit is that for really a very small percentage of the measures, there is a standard established by the state, and that's noted on the report. It's also in the board trending slides, graphs that I present to you, and we can talk about this. In some instances, it's good to be above a standard. In other cases, it's good to be below a standard, and we can talk about that as we move through. What I thought might be helpful would be just to sort of hit the high points of the monthly MCO report, what I see as being trends. I try to look this data over. I calculate some of it, but I try to look over the measures and try to be sensitive to where I see trends and changes occurring. If there's a trend that is noteworthy, I try to bring that up in the executive summary. On the DMA side, the trends that I see are in ED, and not necessarily in order of importance, but certainly ED admits and readmits as far as the raw numbers go. The percent of members receiving services on the DMA side, I think, is really staying pretty stable, trending slightly down. becomes a little bit tough to be absolutely certain about this because of the 90-day claim submission lag. So that in those, when we look at the percent of members receiving services, we have to bear in mind that the last 3 months or so of data, it could be more than 3 months, but the most recent several months will in fact increase over time.
Which, I lost you on which chart I've got so many.
Yeah, no kidding.
Some of them look identical to one another, so I don't,
Page
and I just got lost, because I've got,
Page
sorry.
2 of, where at the top says Medicaid only, this is the very first section.
Okay, is that any, all this be the same as what's on the back of this document also? I need to compare all the numbers.
Yes.
That's the same thing? Okay, good, all right, I was just.
I'm sorry, hang on one second. Yes, it is.
Okay, cool. So
Yes,
that's
that is
different.
I apologize.
Okay, but we're gonna work from this one?
Yeah.
For a minute or two, yes.
No problem, okay, cool. We'll catch up.
I'm sorry, I apologize for the
That's
confusion. What I'm looking at as far as this particular item is in that first section, it says Medicaid only in the upper left corner. About 7 or 8 lines down, unduplicated number that receive MHDDSA services. That is really fairly stable. It's not showing a huge increase, it's not showing a sharp decrease. There's a tiny decrease, but you have to bear in mind that the months August, September, and October may in fact increase as we move along. And this has to do with the 90-day claim submission lag.
Yeah.
There's some time for providers to send in claims, and that tends to inflate those numbers as we move along. I recalculate those every single month. The last 6 or 7 months, I'm sorry, Melissa Isaacs recalculates those, and she's adamant about insisting that that be noted. She is not using old data on that. In other words, it's refreshed every single month. So we know this, and as much as we can foresee the number, and you can see the percent tends to be pretty stable there. There's a slight, if you look at the last 3 months, it looks like a slight decrease, but that's not factoring in the 90-day claim submission lag. So on that particular score, I think the trend is suggesting stability. ED use, we know, is moving up. You can see that this is moving down the same page. Below the yellow section, there's an emergency department utilization. And we can tell that there is some increase in raw numbers there. The rate of ED admits is also tending to move slightly up, so we're watching that. Again, that's not too surprising.
Why do you say it's not very surprising? My ideas, but I don't know any facts. Why do you say it's not?
I think partially because of an increased number of folks receiving services. I think partially because of consolidation. I think partially because of some cultural factors which have to do with the perception that ED use is a pathway into inpatient hospitalization. I think those are the primary reasons there.
Well, there's other things that happen. I mean, I know in one county where a couple of physicians closed their practices.
Oh.
That dumps a huge number of patients into the ED. So this is where this data, drilled down data, is really valuable in integrating the whole, both the physical side of health and the mental side of health.
And what's got me concerned is that, even though, and I grant you, sometimes I look at it from the budgetary side, but you look at the percentage of October 2013 to the percentage of July of 2014, we're talking about 300% increase. Now, I grant you, we're still talking about a very small percentage, but if I read it correctly, the ED admits per 100,000 Medicaid patients, members, that number is up substantially. Now, it's still a very low percentage, but it might be worth monitoring just because of that cost involved.
Yeah.
Do you have this data by county?
Yes.
I'd love to have a look at that if you could.
Actually, we can do it by hospital.
That would be great.
We
By
just
hospital,
did it for Michigan.
by hospital would be even better.
We just did one.
Yeah.
We just finished one doing it for Michigan.
Yeah, that'd be terrific. It'd be great to look at that. this is, I mean, I think the number that probably from a clinical standpoint, the most important is those readmissions within 30 days, both inpatient and also ED. And, it'd be great to see that trending downward. Unfortunately, it doesn't look like it is. It's really pretty steady there at 14, 15%. And I don't know, I know for medical admissions, usually Medicare readmissions, that's average, but I don't know what that is for mental health admissions or readmissions. Do you know what the national average for that is?
Yeah.
Their problem is always because the number is so small.
That's what I was saying, the headache is that when you go from 35 to 60, it's a big increase percentage.
Right.
It's a big increase, all of the relative numbers, but the total volume is still pretty small, but it's still we're heading the wrong direction, but it's not, if it drops by 15 next month, it'll, it's hard, it's not that, it's hard, so that small numbers just skew it.
Yeah.
The other thing that we need to point out here is that we only know this about, this is of course the Medicaid data, and we only know this about Medicaid consumers because we do not pay for the care for persons who are indigent in the EDs. So, and we estimate that possibly Medicaid consumers account for only 50 to 60% of the persons who are seen in the EDs. So it is really, so we don't know any of this about persons who are uninsured.
That's high.
Yeah.
Right, where do I go to get my care?
Keep going back to that.
Primary care.
And it's interesting too that the number of ED admits that were active consumers, that also seems to be trending upwards too, slowly, but it's certainly not trending downwards. I mean, those are the ones that you wish you already had seen, and you were keeping that number pretty low.
All right, do you have any other highlights? I mean, the good thing about this month is that we met all the
We met
standards.
standards on every single item, and the second month in a row in which that has been the case. And yes, I would call that the good news. Interestingly, I will mention this, on both the DMA and DMH side, the number of complaints per month is trending up. And I don't necessarily, I guess my take on that would be that as business increases, I would expect the same kind of process, the same kind of impact to happen for complaints. As a function of doing business, there will be a certain level of complaints that occur in an organization like ours in a given month. As business increases, as we serve more folks, as more claims are processed and so forth, then you can expect some level of increase in complaints. We are seeing that. It can also be a function of greater education of consumers and consumer families and guardians as to their rights and their access, the vehicles, the method they need to use to make a complaint known. So both of those things are occurring out there.
What kind of things are included on the third page under number of authorized requests denied for clinical reasons? Because significant increase there, and I know it's not a huge number of consumers, but went from averaging was like maybe 1.1, 1.2 the first 4 months of the year, and then September and October, 3.2 and 3.3%.
Are you on the
Medicaid side, I
state?
think. That's, I see that on the
Medicaid side.
Medicaid side. My understanding is that is primarily for medical necessity. Is that,
Yes, that is
criteria
medical
not met?
necessity, yes.
I just wonder why it went from 1.1, 1.2 to 3.2 is almost, not quite, but almost triple the average of the first 4 months of the year.
And the head scratcher is that the number of request denied for admin reasons has gone from 8.6 to 9.4 and 10.4, and then all of a sudden, there must have been recalculations, because there's 1.7, 1.4, and then the twos, it's
We
just odd.
calculated it differently at that point.
Yeah, I was gonna say, something really changed.
I believe in the bigger numbers, we included what was called unable to process in there,
Yes.
and
Yes, that is correct.
we changed that methodology. We should put a note on there.
Well, the,
I think that is in the notes.
In the notes.
On the notes tab,
Yeah.
the notes tab towards the,
Yeah.
I'm sorry.
So I usually just explain it verbally.
Yes.
but normally, but more importantly, what Mike brought up about the denied for clinical reasons, like you said, the numbers are low, and it's good to know why that's trending up in a pretty dramatic fashion.
Really, even from the 131 to the 190. Denied for admin reasons.
Or just something to highlight to see if that trend continues in the months ahead.
Okay.
Oh, thanks. All right, we've really
Yeah,
slowed
we
down,
need
we
to-
gotta move the roll on. What else?
Where, should I click on the trending slide?
This
Well,
is the number
if
I
there
would
are
like
any
to see
questions
broken
about
out.
The trends, they really noted most of the trends when looking at the actual numbers. But for those of you who like a visual bar graph type
Thank you.
presentation, this monthly report has the trends in a bar graph type. I would actually, and you might be most interested in looking at the SMC quality NGO comparison report across the state. I don't know if
Right,
that
yes.
interests you.
This one?
Yes.
Yeah, that's, really interesting.
Wait. Holy God.
The MCO comparison report is taken from the monthly report, which we just looked at. The state prepares this usually
That's
once every
unbelievable.
3 months or so and makes it available to us.
Oh
All the
my
MCOs are
God.
compared using the metrics in the monthly report. And this is for the month of September, the most recent month that we have available. And I've prepared a number of different slides here on different aspects of the MCO monthly report. As you move through, this one we start with the state fund side rather than the Medicaid side, and move on through and pick up Medicaid as we get through. Calls abandoned, speed to answer calls, percent of calls answered within 30 seconds, those are issues that we've already touched on here in another context, but if you have questions, please
But that's
stop me.
all calls, that's not Medicaid or.
Correct, I'm sorry, yes, that is correct. The first 3 graphs on call center don't have anything to do with splitting it out between Medicaid and state funds. Persons served, percent of the catchment population receiving services, percent of uninsured receiving services, and the rate of uninsured receiving services. Smokey's numbers are actually a touch higher than other NCOs. So those who are uninsured are receiving services a little bit more frequently in Smokey than the other NCOs. The differences are slight. This is 1 month, and that should be borne in mind. This is not trending data, it's comparative data across the month. It's like a snapshot.
And this is 1 month and it's an unduplicated.
Yeah.
Yes.
Oh my God.
We look at community psychiatric hospitalization, the rate of MH admissions per thousand uninsured, and the rate of SA admissions per thousand uninsured. These are, the SA admissions is using particularly small numbers, but you can see Smokey's admissions are very low on SA, probably in the middle of the pack, very close to the state average, actually not that far off the state average on either side of those.
You can't make sense of it.
Authorizations, our activity there, I think is pretty much within comparative standards. The total percent of audit requests processed in required timeframes is well above the state standard, as is the case for all the MCOs. And I'm just sort of moving through.
Yeah, we do need to.
I know we have a time issue.
Yeah.
I just wanted to say one thing from a clinical standpoint. These hospitalization readmission rates are, in my mind, the most important measures that we have. So, I mean, the rest of the stuff is important, but we're still above the state average in terms of readmissions for mental health disorders. We're above the average for readmission for substance abuse problems. So that, I mean, is if anything that you'd like to drive down to demonstrate really, I think best practice, that would be it.
Okay.
I mean, there's data that shows in the clinical literature that those people who the highest risk for suicide, even for repeat crisis in that first 30 days, if you can address that in that first 30 days, then you actually, clinical outcomes are much better. And, you know, I'm not saying it's easy, but this is really the most important statistic we've got.
Do you have questions or comments about anything else on this? We actually have about 4 more reports on this.
Well, this is great stuff that we can spend.
I know, our meeting
Spend a
is too
weekend.
short.
Yeah.
I see it both on the state fund side and on the residents. It can be well under.
Well, it's really hard stuff. I mean, this is challenging. Reaching people early enough. And it's meaning so that something awful doesn't happen.
No, we're going to quarterly reports. We have the grievance, complaint, quarterly report,
So as Steve talked about this kind of a little bit earlier, there is a
Skipped
trend-
right over incidents? Oh, sorry.
So we're in the experiences, so there is a trend moving upward. In the first page, you see the quarters split out. And so they're giving up. July through September was our highest record of all of proposed incidents.
Complaints against whom?
Other providers, there's providers smoking the system, anything that's
All right, so these are just, like you say, total N, so it's everybody.
everybody.
Okay.
right, but,
It is split out.
So you see how many are the provider and how many are the smoke. The majority, I believe, are for providers, but that makes sense because consumers interact with them a lot more regularly.
So on that first page, you get complaints against or on behalf of a consumer. You see that increase, then that not on behalf of the consumer. With the total N being the 172, so it has to be that. The reasons are next.
So just kind of run my fingers through those, and you see the access to services is going up substantially. Administrative issues. Yeah. Those are the two that seem to be driving most of the increase. And throw it out to you.
And we've actually just started putting in subcategories, because administrative issues can be just about anything.
Yeah, I'm just saying, it's notable that those two, I guess, client rights to some extent, but that hasn't changed much in the past several quarters, but if you go back to a year ago or so. Anyway,
And like I said, there has been an increase in consumers not happy with their schedule times, not getting appointments when they want. I know we had several about one consumer been in several grievances about one particular agency about scheduling practices. So that could drive it up as well. As far as the actual, I'd have to dig into the details and look at the actual 24 to see exactly where they split out though.
This is not differentiate whether these are complaints with validity or complaints with no validity. These are just complaints generally, correct?
Yes, but we treat them all as
I know.
if I perceive that I have a complaint, it's valid to me, so that's how we have to look at it. It's valid to the person calling. But they might not be substantiated. Is that what you're talking about?
You're so much better at this. Yes, that's exactly what you're referring to.
Do you have any other questions about this report? If not, we'll move on to the report and David go from there. Thank you.
So the incident report summary is here. Just real quick, the way we develop this is by tracking the incoming incident reports. This is level 2 and level 3 incident reports, and not level 1 incident reports. No. And those are the only, level 2s and 3s are the only incident reports that are tracked in IRIS. We've had a pretty big overhaul of the incident report team, meaning a complete, a whole new team in there, starting in September. Starting in October. And also the incident report systems was changed in September, so there's a couple changes. And I bring that up because the numbers that you see on these reports are tracking all the way back until July of last year, or this year rather, and the way the information changed and what we're gathering changed. So there's some differences. But this report has all those changes.
Can you just real quickly give me a summary of what the level 2, what kinds of things are level 2 and explain level 3?
Yes, I can. A level 3 is an incident that involves, an example would be a death, a consumer death, that was not by natural causes or by terminal illness. So any other kind of death is accidental.
A suicide, for example.
That's an example of a
But
level
all
3.
deaths are considered level 3 until you get to any sort?
All deaths are considered level 3 until they're downgraded to level 2 because we find out that one of those other two conditions apply. And so other examples of level 3 have to do with the seriousness and does it include bodily harm? You know, if a person is injured to the degree that they lose an arm or leg, or something very, very grievous in that nature, or a sexual assault that involves different degrees of force and things, that kind of thing. And level 2 would be a step down from that. And the level 1s are more like, I hurt my finger and I got a Band-Aid.
The level 3, it has to do with permanent injury, physical or emotional.
Yes. And then, so with this report, the highlights, I guess, would be that there's, on page 2 and 3, this kind of breaks things down by county, and you'll see I've highlighted 5 counties there. And those are just the counties with the highest percentage over this entire time period of level 2s and 3s, based on, or rather up against the person served versus person served. And so what the reason I've highlighted this is just because we want to continue to look at these and see if it has to do with what services are related to the incident reports, and also are there more providers in those counties, or what kind of providers are in those counties. Because some providers do not have to submit incident reports based on their service conditions of service.
So this includes more than just group homes and so forth, right?
Yes.
But might be mistaken in saying that some of the counties that are highlighted have a higher number of facilities than some of the other counties. Am I correct?
Possibly, I haven't broken that down. What I'm saying is that
Dale has one of the highest number of facilities around.
Right.
So those people could have originated from surrounding counties,
Correct.
but they would be then attributed to McDowell.
Right, and I guess what I'm alluding to more though is that it may be that the type of
Yes,
place that the incident is originating from
yes,
may be more of the issue than.
yes, such as the severity of the disability and the individual served might, or the acuity might create more incidents. Yes. And
that's
that's
the
why it
level of-
gets highlighted to do that deeper review.
right, and just try to get a real good picture of where, what's the norm? Really, what we're asking. What's the norm and then where are the deviations? And I don't think we know very 100% yet where that is. I don't know 100%, but what that is. Another thing that with this particular 2 slides is that I think I need to make some changes in how these numbers are generated, mainly percentages, more by month than they are currently generated. So that's another change you'll see down the road.
So we'll see the persons served in each month as opposed to the current number of persons served. So there'll be really a better accuracy, a better correlation.
And those are the main things I wanted to highlight. I don't know if I'm giving the amount of time. I don't know if I have other questions.
It's interesting what you said about the number of Rutherford, we have 3 times the population, and yet the number served in McDowell was higher than Rutherford.
Yeah, because most of the people in Rutherford are seriously served in outpatient clinics.
Right.
They're less likely to have an incident. So, yeah.
But if it's where it's reported from, so you could be from Rutherford County and get your care
And you're reported to McDowell.
and then report it to McDowell, is that?
That's what I'm
It's
getting
by
at, that's what I'm saying,
provider
that's what's hitting it, it's not the McDowell's where it's just that they have more providers where this kind of thing could occur.
Yes, right.
So it skews it by county when you
Yeah.
look at it that way.
Right,
Yeah.
right. No, that's
On page 3, under totals at the bottom,
Yes.
explain how that's. As I'm looking at the second page, that percentage 3.5% versus the bottom page where it's 36.7. Is that a mistake or am I?
That's what they
No,
added up,
I-
that's what they added up all the percentages,
This
it's not an
is,
average of them.
should be looked at more like this. In other words, 2 slides together because it expands the months from quarters all the way across. And so the bottom of that total is actually just June. On 2, the bottom, there is not the totals for all of the information.
I understood that, but
Oh, sorry.
the percentage part is what's.
The 36.7%, I don't see that, I don't think we have.
Oh, okay,
36% was 99,566.
Oh, okay, you're right. Oh,
So-
looking at that.
Looks like you added up that last column.
Yeah.
Thank you. Sorry.
In your judgment, even the ones with the higher percentages, Dow, Rutherford, Norfolk, Transylvania, statewide,
I haven't run these up against the state.
I think the more important thing that we look at is whether the provider handled the incident correctly. We want to encourage providers to report, and we review all the level 2 deaths and all level 3 incidents in a critical incident review committee. And we are finding, for the most part, that providers are doing with the incidents properly. So that isn't showed on here,
No,
but
sorry.
it is,
You're right, that's really more important than anything else,
yeah.
because these things are going to happen.
Mhm.
It's good to keep track of how many happen relative, but it's equally important is how people respond.
Right. And when I worked at the state, we tried to figure out what kind of facility, you know, what percentage should occur in a facility or a service, but you can't because different providers take a different level of acuity. We never really could figure out how many to expect from a certain provider who treats a certain number of consumers.
That's what's so hard to do that because they're gonna deal with what walks in the door. And by trend, just by average trend, you can just blow it out because you've had a couple versus none for the past 6 months. Well,
Yeah, because there's really too many confounding variables to
Mhm.
actually make any conclusions about
yeah,
this data.
yeah, that's tough issue.
So, Carl, is it okay with you if we skip the access to care report this month and bring it next month? Because I really need to
That's good.
focus on the provider satisfaction survey.
Absolutely.
So your provider satisfaction survey is an executive summary document that's 6 pages. It just looks like this. And we are presenting the summary because when you look at the 2014 provider satisfaction survey, it really feels smoky quite a low. We did not do well at all in comparison to the rest of the state. However, I'd like you to turn to page 5 to look at these 2 tables first. And I would like to point out that although we did not do well, we improved. And although we improved, the rest of the state improved more. So you see our numbers of positive responses went up and our percentage of negative responses went down. However, the rest of the state did much better. And the important thing that I'm going to ask Steve to walk you through and point out is that we did improve, if you look at our numbers from Western Highlands and Smoky of last year, that's what we have to consider. So Steve did this excellent analysis and document for us, and I'll let him point out some of the highlights.
The provider satisfaction, provider satisfaction survey is administered in August. And part of the struggle that we had in trying to understand what was really going on with our ratings by providers had to do with the fact that the state administers this survey, and it happened to fall on either side. It very neatly bookended the consolidation of Smoky and Western Highlands. The 2013 survey was administered in August of 2013. The 2014 survey was administered in August and September of 2014, and we consolidated in October of 2013. So, and furthermore, we were the only MCO that experienced a consolidation during this period of time, sandwiched right between these 2 administration dates. And so, one of the things that we were very much aware of was that we needed to factor in, would not be fair to compare Smoky in 2014, 23 counties, with Smoky in 2013, 15 counties. So what needed to happen was to try to incorporate the evaluations of the Western Highlands system into this, and that's what I've done with the data here. The comparison that I'm striking here, if you look at the table 1 on page 3 of the executive summary, what I'm showing here is a comparison of Smoky and Western Highlands composite score, where we combine the positive scores from Western Highlands and Smoky in 2013 with how Smoky was in 2014. and look at what the trend was across those questions for that particular year. And interestingly, what we find is that on a large number of questions, about 18 or 19, Smoky increases its positive scores from 2013, from the composite score of 2013 to how Smoky was in 2014. On a number of those questions, the increase was significant, 10 percentage points or more. And so what the official report, if you will, does not show is that even though Smoky's comparative scores to other MCOs may be low, it's masking the fact that there is a significant amount of improvement and greater positive scores in that particular year. And that's what shows very clearly on the graphs that Julie pointed out, figure 1 and figure 2 at the end of the executive summary. On a small number of questions, Smoky's positive scores decrease in this kind of comparison, and we point this out on page 2, I believe. Searching. 3 questions, Smoky's 2014 positive scores were lower than 2013, and on 1 question they stayed the same. So we've already touched on the next logical kind of question, which is why do we have this kind of discrepancy? And part of the answer has to do, as we've already pointed out, the increase of positive and the decrease of negative scores across all MCOs. The scores of all MCOs as a whole improved from 2013 to 2014. So did Smoky's, but at a lesser rate, if you will. So the detail is on page 3 with table 1, the positive score comparison. And in this case, the comparison that is of issue here is between the column in red, 2013 Smoky Western Highlands Composite, with 2014 Smoky, which is in black. And we've noted the increase and whether there was a 10% or greater percentage point increase in the last 2 columns to the right.
And then likewise, the negative scores decreased and no significance in the same way.
Correct. Yes, that is correct. And this gets confusing because when we look at negative scores, dropping is a good thing. Lower scores are good. And what we see is that on a huge majority of the questions, Smoky's negative scores dropped in many instances more than 10 percentage points, again comparing the 2013 composite score with Smoky in 2014. So I guess the point that I would simply leave you with is that we would argue that the comparison, the straight comparison of Smoky in 2013 and 2014 was not a fair comparison. It was, as the cliche goes, apples and oranges. If you include Western Highlands scores of 2013, you get a more fair comparison of similar types of fruits or vegetables.
Having suffered through that year at Western, the problem is there were so many changes underway and so many things going on. Those numbers are going to skew Smoky's 2013. I think to do, we had to implement so many changes because, we were so far out ahead doing the waiver system. The leadership of the organization initially didn't do a very good job. We had to make a course correction in the middle of the year, a severe course correction, and I think that was reflected in an awful lot of issues. So I take virtually everything in 13 with a grain of salt, and of course Smoky went through the same thing. I guess it was 12 when they first implemented the waiver at Western Highlands, and 13 is when the issues became so apparent, and we dealt with it. In 13, Smoky did the believe we're a year behind.
6 months.
Western Rounds went live in January 2012 and July of 2012 is when
Was it 2012? Okay, so maybe there was about 6 months. What I'm just saying is that there was some benefit of a limited nature that Skokie got from Western being ahead of it, but Western did, the Western management did a poor job, the top leadership. I just think that, and then they had other internal problems, that we were trying to deal with it. It just makes it hard to skew until you get to 2014, you're looking at one thing. Our sole focus as a board and the leader, and so much of the staff, was to right that ship first financially. We got an audit tonight that'll show that we did, although it was very painful. It was, I just don't think I think you're comparing not apples and oranges, you're comparing apples and kangaroos by anything we're looking at before 2014. There's a lot of good numbers in here, but I don't, kind of like that last one, I don't know that it really is worthwhile even to look at.
I agree with you. I'm actually gleaning just from some of what may be helpful in this report, and one is, I look at a couple of these numbers that really reflect training and education,
Yes.
continuing education
Yes.
for providers,
Yes.
communication of best practices, that sort of thing. Have you, those are relatively low for what you would want in a rapidly changing health system where there's lots of new stuff coming up all the time. And I just wondered, do you have a separate process where you've gone through and looked at what are the training needs of providers? Is there done any kind of survey out to them? And is that?
We have actually, we do that in community collaboration. They do that. Don't have results, but they do community surveys and training needs surveys. The other point about education is we got to have some issue. If you look at the question about claims payments and authorization turnaround time,
Yeah.
we use those numbers all the time, practically 100% all the time. So that we need to do a better job of marketing our
Showing
performance.
them how well you do. Yeah, I'm taking any of that with a grain of salt too.
Yeah.
But the perception about, network meetings being informative,
Yes.
trainings are informative and meet our needs as a provider, those are things that I think, there's our opportunities there.
Yes, and actually our provider advisory council, I kind of wish Duncan Sumter had been here because they discussed this and they looked at that question and were baffled because our provider advisory councils are more active, and so one of the things that we looked at is these questions are, we are looking at putting in corrective actions to improve our performance, but none of them are measurable and measure specific activities or functions. They're more perceptions.
Right.
So we have to guess at what we can do internally to address these measures. And we are looking at possibly developing our own very targeted survey to specific functions where we can actually more accurately gauge our own performance as an MCO in regard to provider relations. But Michael, were you going to ask?
I'm having a hard time understanding on table 2 on page 4, when you're saying that the decrease in numbers is an improvement. I don't quite get that because, for example, just pick one, claims trainings meet my needs.
That's because the top, I'm sorry to interrupt you, the top should say percent strongly disagree or
it
disagree.
certainly-
The header is
It
incorrect.
certainly should, and I apologize. I'm just,
Oh, okay, so I was going to ask you
I'm
another
so
one.
sorry.
It says, after the audit or investigation, the LME or MCO requests for corrective action plans or other supporting materials are fair and reasonable, only 8% think they're fair and reasonable? Hey, I'm
Sorry.
going time out, that looks terrible.
That's my fault. That's my
Okay.
fault.
Well, and I reviewed it, so I didn't catch that either, so thank you.
All right.
Does that help?
Yes.
I didn't mean to interrupt you, but I saw it when I started down.
Well, the previous page, there's some key indicators here. If you drop this 2013 data altogether, and you say numbers on the first page, LME, MCO staff responds quickly to provider needs. That's probably one of the, it's a 71%. And that's pretty,
Agree or, yes, agree
Yeah.
or strongly agree.
I mean,
However,
that's,
this is our, I have to point out, this is how we look at it. When you look at the state report, you're gonna find Smoky at the bottom of the barrel on 19 of the 23 measures.
all right.
That's why we had to compare ourselves to ourselves instead of ourselves to the rest of the state.
I don't have a problem comparing, are you talking
Why
about?
shouldn't
now,
we compare to the
Are
rest of
they,
the
are
state?
you talking about 2014 only, when you're talking about the state one?
Look at the bottom.
So if you make the providers happier, you get a better report.
That sounds right.
Which
And
doesn't quite work in managed care.
and our job is to manage care
Yes.
and
Yes.
occasionally, and just occasionally, we have to look over the shoulder on the amount of money. All right,
Where is the state data?
take note down there at the state, so.
What?
So, it's like building inspection.
Oh,
Yes.
it's not in the
We don't
information she
plan,
provided.
we know we're gonna have a certain level of complaints. I mean, yes, it'd be nice to be higher, but the more aggressively you try and, also during this time, I mean, in our county, we went to comprehensive providers, comprehensive care providers. I mean, I guarantee you, we ticked off a lot of people in that process.
Yeah.
They're not gonna be real happy with it, so I'm not saying Smokey's doing a great job, because I don't know, because the numbers don't look good. But there's also more to the story,
Yes.
We gotta take a little Paul Harvey here, so.
Right, and so the way we have the provider satisfaction survey, is it posted on the state website yet, do you know?
I do not think it is yet.
So we will link to that, but we wanted to explain in a different way before looking at the raw numbers, because like you have pointed out many times, looking at raw numbers can sometimes be misleading, and you have to look at the story. So,
It concerns me though, if it stays at that level.
correct, which is why on that performance improvement grid, you'll see a corrective action item for every question on here. So we have taken this seriously, but
The hard part is going to be to prioritize it, because, I really believe with data that, some data is more important, some corrective actions are more important than others.
Yes.
You've got a lot of things. I just, again, emphasize that in terms of really affecting lives, this whole impact on readmission to the ED into the hospital, time from admission to being seen and followed, those are the ones that really make a difference. There's not a lot of numbers there, so it's hard to change the needle, but it's really an important one.
And the last thing I want to share with you is I've just created a little schedule of the reports that you can expect to see every month for calendar year 2015. And in January, when we look at the backup staffing report and the IDD dashboard, I'm going to invite Jesse Snappers, our Innovations Technical Director, and have him come and share. And I may also invite Andrew Donofrio, who does the investigation oversight report, to come as well, because you all are very complimentary of the data, and I would like for you to just get to know the people who actually do the number crunching.
Yeah, that's great. And all the questions and comments are not, you're really delivering the data, you're doing exactly, you're making this more effective, so that makes us feel a bit more, so thank you. This is good stuff.
You're from the state, I apologize, I can't remember your first name.
Yeah.
This is a new type of committee. Based on where you sit, are we doing, I tease you from the state, are we doing what you expect of a committee of this nature? And are we doing a good job from a staff perspective, submitting the reports you all need to make your comparisons or perform your jobs?
I would have to say, based on your first question, as far as a committee, I've served on a number of different, as liaison for a number of different elements now, and so yes, some do it differently.
Well, yeah.
Some, but absolutely, these are excellent reports and very, I was, when I saw them, and I look at a lot of reports, they're very well laid out. There's a lot of information in here, and it certainly sounds like this is the first committee I've attended, but it sounds like you're taking it very seriously, asking some good questions, and that's exactly what you should be doing, as your role is looking at the overall functions of the LME MCO, and as things come to your attention, asking for further information. And as you noted earlier, there's always more to the story than what's on the piece of paper, and so you do have to look at the bigger picture. So yes, and now I already forgot, what was your second question?
I think you answered both.
Okay, okay.
One was, functioning as a committee, and then also the reports you're getting.
Oh, absolutely.
Obviously,
Absolutely.
All right, anything more for you today? Motion to adjourn? Second? All in favor? Say aye. Aye, opposed, nay. Motion carries.